Hello, everybody. Welcome to this webinar on care of the COVID-19 patient for non-critical care physician organized by IRAD Radiology Online. I am Dr. Mahmood. I'm consultant radiologist in London and Chief Executive Officer of IRAD Radiology Reporting UK. As you know, though we are teleradiology company, due to current pandemic, we are focusing on COVID-19 and its management, in particular in the developing countries with limited resources. This very important lecture is part of the educational division of IRAD. Today, we have attendance of doctors from all specialties and from various corners of the world, in particular from the developing countries, which signifies its importance in current difficult times of pandemic. The chosen topic, as you are aware, is care of COVID-19 patient for the non-critical care physician. I believe it would be an excellent learning and sharing experience as we all are combating the pandemic at various fronts. We are extremely grateful to Dr. Tashfeen Mahmood, Assistant Professor of Medicine at UT Health, East Texas, USA, who spared time from his very busy schedule to speak and share his knowledge and experience to handle this menace. Dr. Tashfeen Mahmood, MD. He is a diplomat on 4 American boards: internal medicine, pulmonary diseases, critical care medicine, and sleep medicine. He is also ABIM critical care medicine team writing task force panel member and director of sleep lab UT North. He is a graduate from King Edward Medical University, Lahore, Pakistan. We also have today Dr. Amir Khan, who is senior consultant radiologist at Sheikh Zayed Hospital, Lahore, Pakistan, and co-director of IRAD Reporting. Before handing over to Dr. Tashfeen Mahmood, I will speak about, just to let you know about the poll. About 80% people responded to our poll, and 80% of people today joined from Pakistan, and 12% from UK, and about 6% from USA, and 2% people from other countries. And most of the people told that they have a good weather and their response can be better in their countries, 55%, but they are not very much satisfied. And 10% people said it's excellent response in their countries. I'm going to talk about housekeeping. On the below bar, you will see there is a chat button. You can chat between yourselves and you can report any technical issue to us. And also you can raise your hand if you need to speak to us, but it will be done in the end in the Q&A session. Then there is a button, question and answer. You can write down your questions, which will be answered in the end of the session. You can upvote questions that others have asked if you find that question interesting, and we will answer the most popular questions first. After the webinar, you will receive an email asking you to fill a feedback survey, which will enable you to receive a certificate of attendance. Now I will hand over to Dr. Tashfeen Mahmood to begin, please, his presentation.
Giving me this opportunity to talk about a very important topic here. So we are going to talk about critical care of COVID-19 patients for non-critical care physicians. Here's my disclaimer and disclosure. I'm by no means an expert on this topic, but what we have learned from this pandemic and what we know so far, I'm going to share that experience with you. So like any disease, before you get into the management, you need to know about the disease epidemiology. First of all, I'll talk about a little over presentation. How do these patients present? Unfortunately, there's very non-specific presentation, very variable, and it overlaps other respiratory illnesses like influenza virus infection. The most common thing we see is fever. And fever, cough, and shortness of breath, which was thought to be the most common presentation, is actually not. So I have underlying shortness of breath, which is seen in different studies and different cohorts, about 11 to 40%. And it may be because of the time bias that you're seeing those patients earlier and they're presenting with shortness of breath later. But usually the presentation is more common, a flu-like illness. But you can see there's a countless number of symptoms they can present with. There is an interesting talk about presenting with GI symptoms, and we have seen those patients about 3 to 17% in different cohorts. There was, on CDC website, there's data presented on about 2,500 patients, and about 20% of them were hospitalized. And this is mainly New York data. And ICU admission on journal was about 5%. But again, these numbers could vary from population to population. We see different organ-specific complications as the disease progresses in its time course. The most common is about 20% of these patients develop ARDS. And the patients who get to the ICU, about different studies have looked at it, about 5 to 29% present with renal failure. And almost half of them require renal replacement therapy. We see a lot common that these patients have transaminases elevated in mid-range, about 200-ish. They can develop co-infections. Co-infections are fortunately not that common. And you see mostly in critically ill patients, about 20% of them develop different concomitant viral infections, and about 10% of them develop bacterial infections. This number is a little bit higher if you look at the China data, and maybe the reason is most of those patients were on high-dose steroids, and that's a norm treating ARDS in that country. So you're basically suppressing their immunity and giving them a chance to develop superadded infections. Cardiogenic shock in critically ill patients is seen, and in some anecdotal reports, we have seen that these patients are not that ill, they are on floor, and they may develop cardiomyopathy. Septic shock is less compared to typical ARDS that we call. We'll talk about typical and atypical ARDS in a few slides to come. The data from New York is a little bit different in terms of septic shock. They reported a higher incidence of septic shock in these patients compared to Chinese data or data from other countries. And I personally think, in my experience, most of the time I'm seeing their blood pressure dropping is because of you have to sedate them heavily. So you go on propofol, you go on Versed, or you're going up, which is your midazolam, or you're going up on dexmedetomidine, which is your Precedex. They can develop neurological complications, and nobody knows why it actually happens. There is a widely thought idea that it's probably because of the cytokine storm, but we have seen very commonly that the patients, especially on ventilators who have ARDS and they've been very, very sick, they can develop, delirium or encephalopathy. That happens with any disease, but we have seen it a little more commonly in this particular issue. There was a study in which they looked at actually the CSF analysis, and they didn't they were not confirmed that RT-PCR or any of those patients was positive from CSF. We talk about and we hear about a lot that they develop venous thromboembolism in these patients. They can present with pulmonary embolism is the most common presentation, or they can develop PE at some stage in their disease progression. Stroke, not that common, but some younger people presenting with stroke, and that led to the notion that it's a prothrombotic disease, or there is an issue with hypercoagulability in these patients. It's not been proven yet, but the data from all over the world has shown that this is one of the common things that we are encountering. But again, 50% of the deaths are from ARDS or from respiratory failure in these patients. About 33% is a combined cardiac and respiratory issue, and about 7% is purely cardiac issue. We talk a little about transmission, shedding, and infection, because I think it's very important to know. So far, what we know, nothing is set in stone, but droplet and fomite is the most common. Droplet is one of the commonest way of spreading the disease. There is question about airborne aerosolization, like if there are virus particles in the environment, how long they can survive there. We don't know that they are actually going to cause infection. But the jury is out there. What about virus in stools and the whole blood? Generally speaking, respiratory viruses are not bloodborne spreaders. Virus in stools as well. They have cultured viruses from stools, but is it a real source of spread, like a fecal oral spread? Nobody knows about it, and there's no data behind it. But what WHO and CDC say that it is probably an insignificant factor. And survival of viruses on different surfaces varies. You guys must have seen it, that it can survive on different surfaces up to 72 hours. What about shedding? I mean, this is the biggest concern, that most of the asymptomatic patients asymptomatic folks can be the spreader of the disease. They can be shedding the virus in their sputum, in their cough, in their sneeze. But no one knows if virus detection from the upper respiratory tract is equal to infectious virus. There was a study in Nature published last month which showed that if the copies of RNA are less than 1 million per ml, it is likely not to be infectious. Incubation period, very variable, but general consensus is about 2 to 7 days, can be as high as up to 10 to 12 days, and the median is about 5 days. Well, one thing we know, which has been shown by different countries, different cohorts, that case isolation and contact quarantining has helped reducing the R0. So for people who don't know about R0, simply speaking, R0 is a value in epidemiology that we use to ascertain how the virus is spreading in a community. If R0 is above 1, we're still on the rise. If R0 is below 1, we are getting things under control. We move on to diagnostic workup. We see different lab abnormalities. New York data shows about 90% lymphopenia in these patients, which is, now there are a lot of other patients who would present with lymphopenia for some other reason, so it doesn't mean. So it's a more of a syndrome where you have to collect, your lab data, your clinical presentation.
Excuse me, Dr. Tashfeen, can you please bring your mic closer to you, because many people cannot hear properly.
Okay.
Thank you.
So can you hear me? So lymphopenia, I was talking about lymphopenia. It's a very common lab abnormality on these patients. And the severity of lymphopenia is associated with mortality. We see that mild hepatocellular injury pattern, like in most of the viral illnesses or atypical infections, they can be elevated about 200-ish. Elevated D dimers have been seen very commonly, especially even in the absence of a culprit thrombus or an embolus. You see elevated CK or LDH. Procalcitonin, people who can get procalcitonin, it can be helpful to rule out a superadded bacterial infection. But in severe disease, in ARDS patient with COVID-19 in ICU on ventilators, we have seen elevated procalcitonin levels. We see a lot of elevated inflammatory markers in sicker patients, like LDH, CRP, their ferritin, their sedimentation rate, and interleukin-6 levels can be elevated. And if these levels are elevated, they're telling your patient is very, very sick, and the chances of mortality and morbidity go up. Chest imaging is one of the integral part of diagnosis. Remember, about 20% of these people can have normal chest imaging in the beginning. the most common presentation on imaging would be bilateral ground glass opacities, which are usually peripheral and usually in the posterior or basilar areas. Parenchymal imaging pattern actually progresses as the disease progresses. So initially more ground glass opacities, then kind of mixed pattern, and finally it's more of a dense consolidation changes. Late findings could be fibrotic changes once they survive and get through the ARDS, which is a normal physiological and radiological progression of this disease. But again, the radiological improvement lags behind the clinical improvement. Small bilateral effusions can be seen in less than 10%. That's not usually the case to see large effusions. If you see large effusions, there's something else going on. Point of care ultrasound can be used if it's available in good hands. It's a very handy tool. The learning curve is pretty steep on that. So this is a typical patient. I took this slide from Radiopedia. Actually, most of the patients would look like this. They will have peripheral, bilateral infiltrates, more of a ground glass opacities, just like this on this CAT scan. It's one of the patients from China. So the most important or the core of diagnostic evaluation is reverse transcriptase PCR analysis. It looks at different assays, look at different proteins in the virus makeup, like nucleocapsid, non-capsid, envelope, spike protein, or RDRP. The issue is with the sensitivity of this test. And the reason behind sensitivity is, if you guys understand the basic epidemiology, the most prevalent the disease is, the most likely the sensitivity is to go up on any test. So the sensitivity has varied from 70 to 90% in different analyses. But again, it depends how the sample has been collected, where it has been collected from, and what is the temporal relationship between collecting the sample. The studies have shown that earlier the viral load is higher, and as the disease goes into progression, the viral load actually goes down. There are serological assays, and they don't have much role in diagnostic purposes, but more of looking at disease epidemiology and prevalence. Recently, I think on Friday night, basically FDA approved the first antigen testing. Again, both CDC and FDA and WHO actually warned against taking it as a mere diagnostic tool. So we're not much clear about it because of lack of validation. Procalcitonin, we talked about it. One thing, do not induce a sputum culture because it's risky to aerosolize. Same way, do not culture the virus because of safety reasons. How about you collect specimens in intubated patients? Same way, you go with nasopharyngeal swab. You can do the tracheal aspiration. You can do a mini BAL. In certain cases, you may need bronchoscopy to get an actual BAL. BAL is bronchoalveolar lavage. We don't do it, and American Association of Bronchology and Interventional Pulmonology does not recommend usually doing the bronchoscopy on these patients. I've done one on one of the patients because we were very sure that he has COVID. 2 PCRs were negative from upper airway specimens, so BL turned out to be positive. And there are studies which people have looked, the sensitivity of lower respiratory tract samples is higher compared to sputum or compared to nasopharyngeal swabs. A little over the serological testing. What it would help if you have a hugely validated study and you analyze those patients in general population that they have developed IgM or IgG, it can tell us what is the true prevalence of the disease, or if the patients got infected and they never become symptomatic and they recovered, or if they if they might have developed the immunity against the disease. Now, it's hard to say, what would be the serological correlate of protective immunity. It's not defined. I put there a website address, Center for Health Security, if you want to look at more assays of IgM or IgG testing. Now, after we have learned about how the disease presents and how you can diagnose it, the next important step is how you manage it. Um, in any disease, the most, specifically in infectious and very contagious diseases, prevention is the key. So that's why we talk about social distancing, we talk about lockdowns, and all those maneuvers, cleaning the surfaces, and the list goes on and on. Why is it so important to protecting your most vulnerable cohort of society from getting this disease? And then the next question comes, who do you treat in home? You tell them to go home and quarantine, watch their symptoms, and who gets admitted to hospital? And next question comes, who gets to stay in a general ward and who gets to stay in the ICU? So as I said, preventing exposure is the first and the foremost important thing. Social distancing, you wash your hands, you use sanitizers, and the recommendations are it should have at least 70 to 75% alcohol-based sanitizers. Avoiding touching the face, because mucous membranes are one of the sources. You put your finger in your nose, you touch your eyes, those are the ways you can get infected. Cleaning and disinfecting the objects and surfaces that are touched frequently is very important. There are studies, people have shown that the virus can sit on the surfaces for many hours to days. Use of non-medical mask if no respiratory symptoms. Now, CDC has recommended that. I'm not very sure what is the true efficacy of it, but if it's not used in the proper way, it can actually cause more contamination. What about managing asymptomatic folks with potential exposure? Again, the guidelines would vary from place to place, and depending upon your local guidelines and expertise from local physician bodies and government would define that course. Asymptomatic healthcare workers, what we do here, if you have a documented exposure, either you can go by symptoms or you can go by testing. Now again, these two approaches, if you become symptomatic, are validated. And what I mean, if you get symptomatic and you go by symptoms, so from start of symptom to the end of symptom about 10 days, and then you're fever free and you're symptom free for at least 72 hours. That's the time you can return to work. And if you go by testing, which is RT-PCR again, the recommendations are again, you have 10 days and you are symptom free or fever free, and you do two consecutive testing, which are more than 24 hours apart. And if they are negative, you can return to work. What about post-exposure prophylaxis? There is no such medication which does take care of post-exposure prophylaxis, except you quarantine yourself and wait for your symptoms and then come out. Indications for ICU admission. Hypoxemic respiratory failure is the most common indication so far. So about 100% of those patients who go on ventilator, they have ARDS at some stage, and about 70% in first 72 hours. 41% of all hospitalized patients get supplemental oxygen in one form or the other, and about 6% of them luckily get to a mechanical ventilator. Median time to extubation is relatively higher compared to your garden variety or typical ARDS, but it can be longer. We had a patient last week that we discharged. He stayed in hospital for 39 days and he was on ventilator for 26 days. So again, the concern about tracheostomy on these patients, we tend to delay those because we think the disease is a longer course, so we just wait. We have trached few patients, and I'll talk about technique about tracheostomy on these patients if anyone is interested. How do I do it? Presentation with shock is rare, as we talked about. Cardiomyopathy is usually late presentation, and about 1/3 of the patients do in different cohorts. What are the prognostic indicators? Age, more than 65, different comorbidities like cardiovascular disease, specifically hypertension, diabetes, malignancy, and underlying chronic lung diseases, or being on immunosuppressive medications. They are few risk factors. Higher lab abnormalities. Worse the lab abnormalities, the sicker these patients can be. And those are like your fibrinogen, your D dimers are high, your inflammatory markers are high. What about the patients who are not intubated? How do you take care of their breathing issues? One easy and cheapest way is to prone. Now there is data from before pre COVID-19 pandemic. There is data that it does work, and there are several mechanisms behind it. Improving VQ mismatch in those areas which are dependent, taking load off the heart, improving the hemodynamics, and improving the clearance of airways are one of the few mechanisms. So your oxygenation target in this patient is about keep the SpO2 between 92 to 96%. And how you can do it, you can use low flow oxygen, get a simple nasal cannula. If you are requiring higher oxygen requirements, you go to high flow nasal cannula if it's available, or you can go to non-invasive ventilation, which could be your CPAP or your BiPAP. But once you put them on those, you have to closely monitor those patients. When you go for non-invasive ventilation versus invasive ventilation, it again varies what your institutional policies are. If I go back about a couple of months, what we all thought that, intubate everyone, put everyone on mechanical ventilation because they will ultimately require mechanical ventilation. That's not the case, we have learned so far. And the reason behind that was anecdotal data or older randomized controlled trials in which ARDS patients were not very good with non-invasive ventilation. There's not a single study which has shown that non-invasive ventilation works better than mechanical ventilation in ARDS patients. One thing, high flow nasal cannula has some benefit, but again, not very high quality data. And the concern was aerosolization. So we were very concerned about infecting healthcare providers. I'm not aware of any clear data that high flow nasal cannula actually does increase aerosolization. People have actually looked at it with dynamic photographies and videoing those aerosolization. It goes up to 60 liters per minute and does not cause much aerosolization. But BiPAP does do that. So you really have to be cautious about it, how you are going to do the seal. Seal is very important because when you put the interface on their face, they are prone to have horizontal leak. And that's where the problem comes. So either those patients should be in negative pressure room. And if you don't have negative pressure room, open ventilation is a good concept, which we can use, because if you close everything, I don't see most of the hospitals in our countries like Pakistan or elsewhere have like HEPA capability, like what we see in USA and other developed countries. So they have split unit air conditioners, which are like a place to grow infection and cause more infection. So how do you nebulize these patients? You shouldn't be nebulizing because again, it's a source of aerosolization and infecting people, especially healthcare providers around. So MDIs are as good as nebulizers. So ask patients to have their MDIs, use spacers, and if they don't have it and you have to use nebulizers, take it as an aerosolized generating procedure and use your protective equipment. I would say N95, use eye protection, face shields. Just glasses are not enough. So we move on to acute respiratory distress syndrome. Basics are, it's an inflammatory lung injury, which leads to increased vascular permeability and loss of the tissue, which helps in oxygenation. And it results in hypoxia, and it results in bilateral radiographic opacities, and pathological hallmark is diffuse alveolar damage with hyaline membranes. Now, wait for a minute. A lot of people will ask me that this is what not our typical ARDS is. So we talk about it, the typical ARDS first, and the garden variety ARDS does present with it, and we have ample of data that these patients do have diffuse alveolar disease and damage, and they have hyaline membranes. Now there are some reports on autopsies which show that they have more, and this is from data from SARS-CoV-1 on MERS patients back in 2003 and 2006. in 2009, by the way, which showed that in addition to this, some of these patients have findings of acute fibrinous and organizing pneumonia, which is a pathological presentation, a very rare pathological presentation. So there is an insult to lung, which can present in 100 different ways. So there is no one treatment for anything, whatever you call it, typical or atypical ARDS. The data is very conflicting on it. So simply speaking, this is what happens. So on the right side, you see the abnormal alveolus. On the left, you see the normal, type 2 pneumocyte and type 1 pneumocyte. So what is happening, the increased vascular permeability leads to, and when your antigen comes into the alveolus, actually, the macrophages act as an antigen presenting cell. And what it leads, it releases chemotaxin. So neutrophils come by increased vascular permeability, and the cascade of interleukins and cytokines continue there. And what it does, by some mechanism, if we move towards cytokine activation storm, there is a flaw in the cytotoxic T cells or natural killer cells, and whatever happens, this cascade goes on and on, a self-perpetuated cycle, which does result into the injury to the lung, and it does pull up all the fluid and proteins into the alveolus. So the alveolus is now full of this fluid and this proteinaceous material, and leads to hyaline membrane formation and causes the basic problem with gas exchange. This is the reparative process, and how does your fibronectin comes in, your myofibrils come in, and your fluid is pushed outwards alongside the proteins by sodium, potassium, ATPase, and basolateral membrane sodium, sodium, calcium channels, and you clear off the alveoli, and you may result sometime in scarring. Now, again, the ARDS timeline is a little bit different from typical ARDS. If you look at the Berlin definition, which is, in my opinion, it's a flawed definition, because a lot of that would come into Berlin definition. A lot of ARDS will leave out of the Berlin definition if you just follow, because the duration is insult within 1 week with presentation. So in COVID-19, we see rapid progression from anecdotal reports, but the development of ARDS is usually 8 to 12 days after initial insult, after the symptom onset, actually. And the mechanical ventilation is getting into about 10.5 to 14.5 days. And this is data from, China again. So moving forward, what is evidence-based here? A lot of people talk about high PEEP, low PEEP, more oxygen, low oxygen, non-invasive ventilation or mechanical ventilation. You go by the disease, which way it is going. There is no simple answer on what to do. There is no one answer for every patient. So, look at the compliance on mechanical ventilator, look at who needs higher PEEP, who needs lower PEEP. So initially what we start with, excuse me, nasal cannula. If you have to go up higher, you can use venturi mask. Try not to use humidification, because that leads to aerosolization. You can use oxymizers if they're available, and you up titrate their FiO2 to goal SpO2 between 92 to 96%. Now, again, if your FiO2, initially we put them on 40% FiO2, and we adjust the flow to get that FiO2 to the patient to keep their oxygen between required goals. Now, if FiO2 is going above 50% on either, high flow nasal cannula or on venturi mask, and their work of breathing is going up, or they're going into shock, that's a time you can't keep those patients on non-invasive ventilator. You can't get away with that. You just simply can't. Those patients can be encephalopathic. That is an indication where you intubate. So unlike what we initially said, that everybody who is requiring more than 4 to 6 liters of oxygen on nasal cannula just gets straight intubated, we are not doing that. So a little bit about that, and some of it I've already said, that you can go up on high flow nasal cannula if you have available up to 60 liters per minute. Now again, institutional policy plays a role. Here at UT, we are not doing that, but it can be done because one, there is no data. Whatever data we have, it does not aerosolize as much as we thought about. BiPAP, it does. You use the inline viral filter if you have it available. Try to use double limb, because all these non-invasive CPAP or BiPAP can have a single limb. So chances of infection, reinfection are high, chances of aerosolization are high. If you have to use a nebulizer, use inline nebulizing, and ensure the mask is tightly enough fit. And if you have negative pressure room, use that. There's nothing better than that. If you don't have, use ventilator. Now let's talk about ventilation is natural ventilation. And you can find on WHO website that if you have a room and you ventilate or recirculate the air about 12 to 14 times, it is actually better than a negative pressure room. So keeping windows open, keeping the doors open is a natural ventilation, which actually does well in temperate climates like Pakistan. Very important. Go to CDC, look at how to put on the PPE, look at how to doff it, because doffing is a problem where most of us are at highest risk of contamination. Intubation. Now I crossed the early intubation just to reiterate that there's no early intubation. The intubation is when intubation is needed. And this was because of the case reports earlier from China that there is higher failure rate from non-invasive ventilation or high flow nasal cannula usage. And then aerosolization was a risk and is still a risk on BiPAP. CPAP up to 20 centimeter, people have looked at it, it does not cause much aerosolization. So many experts, and including what I do, is rapid sequence intubation, and we paralyze a patient. We don't use the the bag mask technique, and it's a very narrow pin that you can use for pre-oxygenation venturi mask or high flow nasal cannula, and you have a shot. So it's not a time to I want to learn how to intubate. It's not that time. So the intubation has to be done by the most experienced operator. General management of ARDS, this isn't just an overview, we'll talk more about it. Treat the underlying cause, support oxygenation, which you can do by FiO2, by PEEP. There is a driving pressure concept. If somebody is interested, and I can ask those questions, but for general purpose, you support the ventilation. Use lung protective low tidal volume mechanical ventilation by limiting plateau pressure. Now, what is lung protective low tidal volume mechanical ventilation? Is closer to more physiological. Remember, when we are breathing spontaneously, we are generating a negative interpleural pressure to suck the air in. When you are using mechanical ventilator, you are going against nature by pushing air with pressure inside the lungs. So how much tidal volume you can give, it actually depends upon how much pressure you are giving, or how much, if you are volume targeted ventilation, how much compliance is there that is going to generate the intrathoracic pressure or intraalveolar pressure. So this is one thing that we know for last 2 decades from ARDS-NET. Out of the 2 things which actually do decrease mortality in ARDS patient is low tidal volume. There is non-ventilatory support, conservative fluid management. Now, it sidelines a little bit from current understanding on COVID. These patients can have fever, they can be volume depleted. So I'm not saying that every ARDS patient or every patient with COVID-19 do not give them fluids. Go by your clinical acumen and patient management at bedside. Assess their fluid status, and then go with whether you're going to give fluid or whether you're holding the fluid. But as a general rule, an ARDS patient, the drier the lung, the happier the lung. There are salvage therapies on refractory hypoxemia. So this is what a very, very nice article in Intensive Critical Medicine published a few days ago, in which we compare from 1970s to 2020 what we have learned so far about mechanical ventilation. So less is more. So everything you see, we were going on higher tidal volumes, higher PEEPs, mega dose of steroids, mega doses of nutrition. We've learned that we don't need that, actually causes more harm. Single slide to look at the ARMA trial, which was the ARDS-NET, practice-changing publication, which showed, if you look at the blue columns only, days to discharge, breathing unassisted, vent-free days, barotrauma, mortality, benefit in all if you use 6 ml per kilogram predicted body weight, tidal volume to ventilate these patients. These are just the slides I put there. If you look at, for example, a 5 feet, 10 inches male what would be their predicted body weight, and based upon that, they have calculated based upon 6 ml per kilogram total body weight. Now, this is from Society of Critical Care Medicine, and everybody does agree with that, on ARDS patients, mechanical ventilator, go by 4 to 8 ml per kilogram predicted body weight and keep your plateau pressure less than 30. Plateau pressure is once you have blown air into the lung and there is no flow, you stop the flow. The pressure at the mouthpiece or the pressure at the end of the airways is equal to the pressure in the alveoli. In simple terms, that's what plateau pressure. So keeping the plateau pressure as low avoids the barotrauma to the lung, avoids the volume trauma to the lung, avoids the atelectatic trauma to the lungs. PEEP is positive end expiratory pressure. This is the pressure, or this is the same thing as CPAP is, concept of splinting things open. So when your alveoli are full of fluids, they're not gonna be taking part, but the normal alveoli are being protected by applying PEEP, because when they open, close, or for the loss of surfactant, they're open, they're not going at their physiological FRC, so your FRC is depressed. So by causing that stress trauma, you are inducing lung injury. So by keeping them open at end expiration is what PEEP is. So patient exhales, and you stop there. The ventilator stop there. So there is a pressure maintained in the alveoli which keep them open. It helps with oxygenation. It minimizes repetitive atelectatic and opening lung injury, but it can cause systemic hypotension by decreasing the venous return. Now your intrathoracic pressure is high, so your inferior vena cava or superior vena cava return, specifically inferior vena cava, venous return to right ventricle is decreased. And we know that most of these COVID-19 patients, one of the phenomena is their RV function is depressed. So this is one table. You can Google it by ArtsNet and you can look at the PEEP strategies. But now again, different institutions have sometimes their own PEEP strategies, their own PEEP tables. A simple concept, on the left you see, on the left top corner, you see the normal aerated lung on the top. Then there are 3 zones. One is the grayish zone and one is the whitish zone. So the white zone is where your fluid or pus or whatever it is there. This area is not recruitable. But the area in between the normal and this poorly non-aerated area is one that can be recruited by applying PEEP. So L versus H phenotypes. A lot of people would be interested. This was a concept given by Gattinoni, and now Marini joined it, and it was published in intensive care medicine in early April. And then later in JAMA it showed up, JAMA or New England Journal. But what it basically talks about, is there is some kind of peculiar problem with COVID-19 patients that when they present earlier, we call it L phenotype, which means there is low VQ perfusion ratio. They are less recruitable, meaning there is less weight, there is less fluid in the lung, and you don't need that much PEEP. And that's what our usual norm has been. Like for COVID-19, we recommend lower PEEP to start. By lower PEEP, I don't mean 5 of PEEP is going to work, but again, it's your bedside judgment, what you're going to do. A lot of people talk about that there is a problem with vascular regulation, like hypoxic loss of hypoxic vasoconstriction in these patients. And I think there is an issue, and I don't know what is the actual cause of it. It may be, heme-mediated nitric oxide scavenging, or simply term people say that, because of higher ACE levels, there's more vasodilatation in those areas. So you lose your hypoxic vasoconstriction in areas where there's not much oxygen getting into the alveoli. So that's how you cause more shunting and you cause more hypoxia. Now the typical slide, typical ARDS is 1 at the bottom. So you look, the P to F ratio in both is less than 100. But you see how bad the lungs look in the typical ARDS. And these are the patients which will lie in the higher PEEP requirement area. Now, again, if you look at the Boston and Seattle data, the PEEP were pretty high in the beginning and it didn't change much. So to back up the idea of get noni, there is no much data. I mean, simply, I don't know how to prove it. But there are proponents of it and there are opponents of it. So during mechanical ventilation, how you collect samples, same way, nasopharyngeal, tracheal aspirate, mini BAL, or if you have to do, BL by using bronchoscopy, use your face shield, use your N95 or PAPRs if you have available. Weaning and extubating, importantly, do not do cuff leak on these patients. Because of aerosol addition risk. And do not use TPs. At some places people do it. I sometimes use TPs, but not on these patients. Please don't use. And make sure these patients are more ready than your usual patients, because there are reports that they get reintubated. In my experience, it has not been the problem, but beware of that. A lot of people have asked me that, how do you do CPR on these patients if they are prone? We'll talk about proning in a little bit, but CPR is same. You prone, you can start CPR in proning position. There is plenty of data behind it that it does work, and there's no difference. But wear your PPEs, avoid bag, mask ventilation. Tracheostomy, if you have to do tracheostomy, what I do, paralyze them, and you do the mechanical ventilation hold. So you do the hold. That is a time where you have 5 to 10 seconds to put your dilator and put your tracheostomy tube in. So fluid, very important. Again, from ARDS, what we know, this is more than 1,000 patient data, and that's what we do. Conservative strategy is better than liberal strategy in terms of fluids. But again, your COVID-19 patients can be different, especially in the beginning because of fever, tachypnea. So this is a very simplified approach using CVP. Now, again, we know that CVP is a flip of a coin in terms of determining fluid status. So use, if you have available, pulse pressure variation, or if you can use the ultrasound to look at their inferior vena cava, collapsibility index. Life-threatening hypoxia, there are ventilatory strategies, and there are non-ventilatory strategies. Neuromuscular blockade, we do paralyze them if we have to. Accuracy trial in typical ARDS, which is your typical ARDS, by definition is, your atypical ARDS is if you optimize their mechanical ventilator settings and within 12 to 24 hours, their P to F ratio improves by more than 150, it is atypical ARDS. So there's no rocket science behind it. What about prone positioning? It does work. ProSeva trial is there, which I'm going to show you in a little bit. Pulmonary vasodilators have been looked into the past. There's no data behind it that they improve mortality or morbidity. And for COVID-19, we have no data. ECMO does work. I don't know if ECMO is available in Pakistan, but in our experience, VV ECMO still work if their heart function is good. Prone positioning in severe ARDS, if you want to read an article, read that in New England Journal in 2013, ProSeva trial, which showed that 28 and 90-day mortality significantly improves if you early prone them. So there is a eligibility criteria for proning. If the patient meets that, you can prone them. Now, some people say that early proning is not needed in COVID patients, but I think it has been shown that even if you are spontaneously breathing, early proning does work. Now, we don't have to prone many patients. I'll tell you from my experience that they do okay by adjusting their FiO2 and PEEP levels. So if there is contraindication to proning, and if you have ECMO available or they have failed the salvage therapy, you can go up to ECMO. So this is what's the definition of refractory hypoxemia is. And so, your plateau pressures are going up, your FiO2 is going up, your PTF ratio is still low, and you have proned them already. And you have used nitric oxide. So in our experience, nitric oxide does work by improving hypoxia, but it's not long lasting. It's very, very expensive. You can use inhaled prostacyclins, but then again, the data that they improve any outcomes is minimal, if any. Again, to achieve low tidal volumes, tolerate hypercapnia. pH is not your goal. pH is your goal, PCO2 is not your goal. So manipulate respiratory rate, tidal volume, keeping your platelet pressure less than 30. If you have to sedate them, paralyze them, or initiate prone ventilation. In addition to those things, the things which matter is stress ulcer prophylaxis, because if your patient is in shock, they're gonna have a GI bleed, and glucose control, nutritional support, VAP prevention strategies, which is ventilator-associated pneumonia, using nebulizing medication and mechanical ventilation. We've talked about it. Sedation and analgesia, make sure you're doing it appropriately and judicially. So antibiotic stewardship, if you are on antibiotics, cut them down if there's no real evidence. Manage the fever. There's a controversy about using NSAIDs. We are not using NSAIDs, we're using Tylenol or acetaminophen. Glucocorticoids have always been controversial about ARDS, even with typical ARDS. We don't use steroids unless there's a compelling indication. Hypercoagulable state, there's more and more data. So I'm just gonna talk about indications. If there's clear-cut documented VTE, PE, or DVT, you anticoagulate them. If there is high suspicion, plus they have either MI, acute MI, CVA, or massive PE, on echo you see RV strain, or there is a moving thrombus or embolus into the pulmonary artery, you do TPA. If there is no contraindication, of course. If none of the above, but they are on home anticoagulation, we usually continue those if there is no contraindication. If none of the above and there's not on home anticoagulation and they are being admitted to the hospital, then all of them go on prophylactic VTE doses of either low molecular weight heparin or heparin IV or subcutaneously. If they are going home, we usually don't anticoagulate them. Monitoring and outcome. Daily labs are necessary, but not imaging until something has changed. Pregnant women, same management. Sickle cell disease, if they develop acute chest syndrome, you can do exchange transfusions. The same way you manage that. And mortality is mostly from severe ARDS, as I've already told you guys. The rapidity of symptom progression does not appear to predict a worse outcome. So high-grade fever has a high risk of ARDS, but not necessarily high mortality. Other management issues: do not start ACE inhibitors or ARBs. There is no evidence behind it. If they are on it, just continue them. And don't use hydroxychloroquine prophylactically. Statins should not be used. And there are specific therapies. For example, remdesivir. Recent trial by Gilead showed that these patients get 30 times faster, better compared to patients who go on placebo. So 11 versus 15 days, and mortality 8 versus 11. So we don't have it available. It has been under trials. If you are part of a trial, you get it. Otherwise, no. There was a compassionate availability earlier, which was not. So we don't have much experience with remdesivir. Hopefully, it will be available now, but we still don't have it. Hydroxychloroquine plus azithromycin, I don't use that. There's no data that it works. Convalescent plasma, we're part of Mayo Clinic trial and we're using it. We have huge success with it. Interleukin-6 pathway inhibitors, some people with tocilizumab have amazing experience, but the data is still not published and there's not enough data. In my experience, it has not changed drastically the management. Ritonavir, lopinavir, there was a negative trial from China in New England Journal. Immune modulators, whether to continue or stop them is a matter of debate. Interferon beta, no evidence. Hormonal therapies, people are looking at progesterone therapy, no data. Timing of above therapies is at best is unknown in severe versus non-severe disease. We don't know when to give. Some people say earlier is better. Some people say wait for cytokine storm. The last thing is delirium, pain, and agitation. So we manage their pain, first of all, use opiates. There will be a shortage. We already are seeing it. We use fentanyl, so we go to patches of fentanyl if you have to use, or alternate agents like morphine or Dilaudid, oxycodone or oxymorphone. Non-opiate analgesics can be used to cut the requirement. And this is the data enough. If you bundle your spontaneous awakening trials with spontaneous breathing trials, the outcome is better in terms of mortality, in terms of getting them off the ventilator early, in terms of getting them out of the hospital. Now with COVID, it may be a problem because of PPE availability, because of having enough staff going in, doing physical therapy with this patient and whatnot. So sedative agent, we try not to use benzodiazepines unless there is some other indication. We use dexmedetomidine less than propofol, but you can see, their blood pressure dropping. You can go on to intermittent doses of those. What about delirium? We see delirium or encephalopathy common in these patients of COVID-19 disease than other ICU patients. And again, it is associated in general with increased mortality, prolonged ICU and hospital length of stay, and development of post-ICU, PTSD or cognitive problems. So how do you prevent early embolization, early mobilization? Early mobilization. So again, there is enough data to show that early mobilization does work. We don't suggest using Haldol or atypical antipsychotics in these patients, but sometimes we use like Seroquel. And there's no data that Precedex or dexmedetomidine prevent delirium in adult ICU patients. But again, there will be an issue with specific COVID-19 patient population with doing early mobilization because of staffing issue, because of the PPE and issues of getting infected on healthcare workers. So this is the recommended framework and ICU Liberation Collaborative. This work was done by from people from Vanderbilt earlier, and they are proponents of pain, agitation, and delirium guidelines, PAD guidelines, and it suggests A, B, C, D, E, F. This is just you assess their pain, you bundle the SAT and SPT, and choice of your sedative agents. You manage the delirium, and you do early mobilization, and you involve the family. So by doing all that, they've seen that their ICU length of stay, their length on mechanical ventilator, and their mortality actually goes down. Thank you very much.
Thank you very much, Dr. Tashfeen Mahmood. It was an excellent talk, and I think we all got a lot of information about management as well as its pathophysiology.
Thank you very much, Dr. Iftikhar. I'm Dr. Amir Khan, consultant radiologist and director at IRAD. I thank you all, particularly Dr. Tashfeen, for taking out time in this wonderful academic activity. A few words about IRAD. It is a teleradiology platform created by experienced and qualified radiologists with a passion to serve in developing areas, particularly in Pakistan and in South Asian countries, with an aim to provide imaging services of international standards. The company comprises a panel of radiologists, primarily with UK-based qualifications, and would be providing general reporting, subspecialty reporting, out-of-hours scanning, and multidisciplinary meetings with a view to help clinicians in their decision for best patient care. Basically, IRAD is able to provide a virtual radiology department to healthcare facilities and diagnostic centers. Virtual radiology department to healthcare facilities and diagnostic centers in big cities and in remote areas. Both private and public hospitals. For that matter, please visit our website for more details. At the end, I also thank the following organizations who actively took part in the promotion of this educational activity. and these are Association of Pakistan Physicians and Surgeons of UK, Pakistan Society of Gastroenterology and GI Endoscopy, Allama Iqbal Medical College Alumni UK, Pakistan Academy of Family Physicians, and Doctors Con. Thank you once again for being with us. Over to you, Dr. Iftikhar, for question and answer session. Thank you.
Okay, Dr. Ahmed, thank you very much. Dr. Tashfeen is going to answer the questions. I think most of the questions probably has been answered already in your talk.
Yes, I can quickly, run through them and tell you.
Okay, that's fine.
The question was, do you want me to, or you want
to? You can carry on.
Okay, very good. So Dr. Mohammed Asghar asked that is surgical mask effective to avoid COVID-19? Again, we don't know. I mean, in my opinion, no. It depends on where you are. If you are in a patient room where there is aerosolization, yes, surgical mask is ineffective. It is not going to be, anywhere close to N95 mask. If you are in community and you are in a big gathering where people are sneezing and coughing on you, surgical mask may have some role. Or if you are coughing or sneezing, surgical mask may have some role to prevent spread of the disease. But nobody has looked at that, how preventive it could be. And the basic reason is we don't know what is the prevalence in certain geographical areas if you implement those things. Not only if you implement, if you have not implemented, even then, because of the serologies available pretty late into the disease, we may know it better now, how many people are affected and how many are not, by doing those measures. Dr. Tariq Mahmood asked me that why number of deaths in Pakistan are much less as compared to USA and European countries. Well, people from Pakistan should tell me that. But one notion is that, how you test, what is the number of patients you are testing who are presenting with very non-specific symptoms. So if you look at the overall data from all over the world, what is a country which has tested more and has come back more positive is USA. If you look at the case fatality rate, it goes around 6%. If you look at the case fatality rate in England, it's about 14%. So number of deaths per 1 million in USA is about 23 versus UK about 47. If you look at the Pakistani data, I agree with you. The number of deaths per 1 million is less than 1. I mean, I don't know if many people are dying at home, if you are testing them enough, or what is the end point? I mean, were they positive or not? No one knows. So that is one thing, I think playing major role. I can't, okay. PPEs used for, elaborate the PPE used for critical care unit for COVID-19 patients. Well, again, I showed the slide, go to CDC website and you will find all the information. What we recommend is, what I use, I'll tell you, I use N95, I put a surgical mask over it because of, availability of N95s. So you don't want to, if you're seeing 20 patients, you don't want to discard an N95 mask after every exposure. So you can remove the surgical mask, but you have to be really careful. I use double gloves. So I take off the top glove and put on new glove after it's contaminated. I use face shield. So use the face shield if you have it available. And I'm usually in my scrubs, and we usually have a yellow gown, which does protect from most of the spillage, or if you're expecting that. So it again depends on what you have available. But if you don't have those available, I would still, at least have an N95 or use double surgical gloves. Now again, does it prevent the exposure risk? In my opinion, no. So you at least need the, if you are dealing with, secretions and all those stuff and aerosolization procedures, then you have to use N95. So how a standard way, a good doctor to deal with a COVID-19 patient in ICU is his approach is up to the mark. In less developed countries, its WHO standards are going to be done by countries like Pakistan and India. Well, again, luckily Pakistan and India has not seen that kind of surge as we have seen here. And I'm telling you that even before this pandemic, if you look at the academic data from USA, the things we know from last 20 years, how to best manage ARDS, are not being implemented even in developed countries. So the answer is probably not. This is a very interesting question. Persons who had first attack of COVID-19, are they immune from second attack or not? I wish they are, I hope they are, but we don't have data. And the problem with this is that we don't know, does everyone develop protective antibodies? And how long those antibodies last? My journal thought would be that, you know, like if you compare it with influenza or any respiratory virus, it may be protective for a few months to maybe a year or maybe up to 2 years. I simply don't know the answer. Causes of false positive RT-PCR COVID-19. Again, I think I answered this in one of my slides. You know, it depends on what is the assay you are looking at, how validated it is. What is it looking at? What kind of protein part or antigen part of the virus it is going to do the PCR? And what, where is it collected? What stage of the disease is collected? So all those factors play a role. So next question was, what are the new interventions are carried out in the world regarding COVID-19 patient treatment? I think there are about over 1,300 trials are going on right now. If you go to trials.gov, you can find the, you know, all the details, but nothing is set in stone that it works, except so far the positive trial is remdesivir. And, you know, soon we will have convalescent plasma trial results coming out. And in our experience, it does work. And then the best practices that we talked about during this lecture to prevent complications. What is the outcome of intubation? Well, most of our patients got extubated, and one of them got trached, and he didn't get trached because of the respiratory issues, but mostly because of his encephalopathy. What are the indications for tracheostomy in these patients? Indications are same as for any tracheostomy, but as I said, we usually tend to wait a little bit longer because of two reasons. One, we know the disease itself is lengthy. These ARDS get better a little late. And secondly, there's a risk of contamination, so we tend to delay tracheostomy as much as we can. The rest of the indications are the same. You know, you cannot get them off the ventilator. They're encephalopathic, they can't follow commands, and, you know, this goes on. Role of PPE in non-critical patients. I did not understand the question quite well, but are you talking about, you're seeing non-critical patients outside in the ward or in the clinic? Should you use PPE? The best practice would be to screen those patients. You know, what we do here in our clinics, and it may not be possible everywhere, we give them a call before the visit. We screen them. Do they have shortness of breath, fever, blah, blah, blah. And when they come to the hospital, we do a second screening at the entrance. And what we do, check their fever, ask them about those symptoms quickly again, and then they come in. We use telehealth a lot, telemedicine. Like up until today, I'm not seeing more than one person patient in my clinic. So I'm doing all telemedicine. So if you can call them, you know, I don't know how the setup is in different countries, but that's what we have been doing. And this is going to open up, especially I'm talking about in Texas, we are started to open up about 25% of, you know, our clinics. We have stopped doing the elective procedures, but we have opened about 25% of those elective procedures. So I would still suggest that you consider everyone you're seeing in the clinic or hospital as a positive case, especially if it's high, the infection rate is high in the community, like where we are. So I'm taking every patient, and I have my N95 on, seeing every patient. Role of antibiotics in treatment of COVID-19 patients with severe lung involvement. Very good question. And I think I would go with a clinical picture. If they are deteriorating and the infiltrates are dense and they are earlier more consolidative, I would put them on antibiotics. But again, beware that antibiotics are not there to stay forever. If you have procalcitonin available, do that. Less than certain cutoff, the chances of a significant bacterial infection are very low. We use it to de-escalate the antibiotics too, but use antibiotics if you have to use them earlier on, and you can always de-escalate them, get the sputum culture if you can, and based upon the results, you de-escalate. Sometimes they develop superadded infection, especially if they are on mega doses of steroids. You have to add antibiotics then. Dr. Tahir Chaudhary asked me a question: what is the status of hydroxychloroquine and azithromycin used for COVID positive or suspected patients in USA? So, very good question. This is the first part of question. A lot of people at our institution, I know we have a group of 11 intensive care physicians here, and most of them are not using hydroxychloroquine and azithromycin combination. I don't use it either. And the reason is, if we are part of a trial, we would use it. But there are several trials going on. And you rightly mentioned a study in New England Journal of 3 days back shows no benefits or harm in using hydroxychloroquine. So, I mean, it's more, for me, it's more of a placebo. I don't use it, especially not with azithromycin, because we have seen the QT issue. It does get into more problems. So unless I have more data that it does work, I would use it. But mostly what I've heard from friends in New York and other states who have used it quite a bit, they in their experience, it does not work. But more data to come from a well-done study. How important is to treat COVID-19 with systemic steroids? If you look at the CDC and WHO guidelines, they do not recommend putting them on systemic steroids. Now, it may vary from physician to physician. I use them only if a patient has underlying COPD or asthma and I'm thinking it's exacerbated. Bilal Absala asks, what is the drug regime for COVID-19? There is none. And somebody asked me, what is plateau pressure? I think I answered it. When you hold the inspiratory cycle on mechanical ventilator, the pressure at the mouthpiece, which is thought to be the pressure in the alveoli, is a plateau pressure, considering there is no flow. Dr. Askar asks how much tidal volume to give safely. The less is the better. And that what leads to, to the question about driving pressure, which is, again, another kettle of the fish. A long discussion would lead us into, but we know that lower the tidal volume, the better it is. We usually start at, anywhere between 4 to 8 cc per kilogram of predicted body weight, and you can calculate predicted body weight based upon formula from ArtsNet trial. Just Google it, you will find it. And then, you give them that volume and then you get the gases and see where they are, or their FiO2 is matching with the PEEP. So basically, lower the tidal volume, the better it is. So next question is, if a person has exposure contact with a positive patient, what if he takes chloroquine once weekly or healthcare worker use it weekly? I mean, he can do whatever. I don't know the answer, would it work or not? But specifically, I would not recommend it, that they go to a pharmacy and get this and start taking it. Again, there's no data. I mean, I cannot, suggest anything in that or recommend. Any role of anticoagulation in COVID patients, considering vascular thrombosis as basic pathophysiological mechanism? I don't think this is a basic pathophysiological mechanism. A lot of these patients do have microthrombi. In the absence of PE, diagnosed PE or suspected PE based upon high RV pressures, or if they have DVTs in their legs, we don't anticoagulate everybody. But if they are sick and their D-dimers and fibrinogen levels are up and their X-rays are getting better, but they're still not getting better, we use anticoagulation. Or in some other instances, we use TPA, thrombolytic. But again, this is the concept of microthrombi in ARDS is not new. It's well known, and a lot of these patients do, and that's the basics, you know, of problem in vasculature. Either it's RV malfunctioning, either it's microthrombi, or either it's a pathophysiology related to autoregulation in your vasculature that is not able to sense the hypoxic vasoconstriction and leads to high VQ mismatch and shunting. So yes, I think there was one slide I mentioned which patients should be anticoagulated. Does it infect eyes because of redness of eyes? I have not read it anywhere on the symptoms that red eyes can be one of the symptoms of COVID-19. There was something in the news a couple of months ago, I think in March, from Washington, that somebody, a nurse in a nursing home, reported that she saw everybody who was elderly in the nursing home had red eyes. But I honestly, I don't think so. I have not seen that. Are there more than one strains of COVID-19 circulating globally? Yes, I think there is evidence. And another important thing is, unlike influenza, luckily, as of now, what I know, you know, talking to different ID experts, COVID-19, SARS-CoV-2 is not as mutating as rapidly as, you know, flu would. So I think a vaccination would be a good solution. It's okay. How common is anosmia and dysgeusia symptoms for COVID-19? Case series have reported up to 70%, so pretty common. WHO data supports no claims that antibodies developed during its attack will protect the patient from, yes, because they need evidence. We don't have evidence. But what we know that the convalescent plasma, if you take from a recovered patient, does work. Now, again, if you ask me what are the neutralizing antibody titers on these patients, we don't know. We just simply give it and wait for the results. In our experience, it has worked most of the times. What is your experience about ECMO if ventilation doesn't work? Yes, it does work. Like in any ARDS, if your standard ventilation or anything you have done on, after optimizing ventilation with proning, it has not worked, we go for VV ECMO, or if the heart is in trouble, we go with VA ECMO. It does work wonderfully. Heard that people with dark and darker skins are more at risk of contacting COVID-19 due to lack of vitamin D. Can you please explain this? I'm sorry, I cannot. I don't know, but there is some. There are some reports that vitamin D deficiency patients may be at higher risk of contracting. I don't know the pathophysiology behind it. Tariq Mahmood asks, is there any difference between a cured COVID-19 patient and a normal person? Very good question. It depends on what they're what stage they're cured from. You know, if they have been on in ICU on mechanical ventilator, yes, they're going to have significant muscular and neuropathies and what we call the critical illness related myopathies or neuropathies. They would need a lot of physical therapy or rehabilitation to recover, and their lungs may not come back to normal. They may have residual fibrosis and whatnot. Different psychiatric issues, we see them. Next question was, have you used remdesivir and your opinion about its effectiveness? Yes, the trial is positive, more data to come. It's not peer reviewed by Gilead, but it shows that these patients got 30 times faster in terms of improvement, and the mortality was lower compared to 11% of controlled arm. So 8 versus 11% from placebo arm. So yes, it does work, but I have not used it. Initially, we had some by compassionate use, but we couldn't get after that. We are not part of a trial, so I have not experienced it much. How vulnerable is a patient on oral treatment of breast cancer is to acquire COVID-19, and any extra care required for such patient? Any any immune suppressive medication would increase your risk of getting the disease, and maybe presenting with atypical symptoms. May not have high fevers, may not have more shortness of breath just because of neutrophil, if their neutrophil count is depressed. So yes, they are at a high risk. The extra care is same. Wash your hands, keep yourself distant, and if somebody is exposed, stay away from them. Again, you can use some surgical mask if you're in a gathering, but avoid social gatherings. In developing countries like Pakistan, where prolonged lockdown is not possible due to economical reasons, compulsory use of masks by all can be an alternative to some extent. This seems like a comment and a question. There was a recent suggestion that endobronchial lignocaine can help. What are your views? But I don't know anything about it, honestly. I don't know what would be the mechanism behind improving that outcome. Patient with insomnia and slight depression, can they be given anxiolytic or antidepressant? Absolutely. Sorry for late joining. You may have answered this before. What about parents who have typical symptoms but PCR is negative? Yes, very good question. PCR negative, if they have symptoms, I will treat them as positive. And this leads to another question. If they are not available testing, you can presumptively call them as positive and treat them. By treating, I mean monitor them closely. If they are locked in at home, quarantine them, and watch their symptoms of worsening of hypoxia, shortness of breath, or fever, whatnot. Treat fever with antipyretics, and keep them well hydrated, depending upon how they are. Virus have a mutated form in Pakistan and so less virulent. Do you agree? I don't know the answer to that question, and if somebody is able to show that mutated form and bring it on, because if it's mutated, it must be pretty easy to bring it up. I'm not aware of that. We GPs are not treating COVID patients. We are examining general patients. Please tell us what measures should we take to prevent ourselves and other patients, and if some solution aerosol can make our clinic safe. Dr. Mohammed Yunus. So yes, I think I've answered this question. What we do here is screen them and take them, limit your physical examination if you can, like what we are doing in tele-ICU. Again, I would take every patient as positive. If it's widely spread in your community. Even, any kind of solution which contains 70 to 75% alcohol, or it has chlorine or chlorhexidine, can be used to disinfect. I know a lot of people use Dettol in Pakistan, and if you look at their website, they claim that based upon previously tested coronavirus strains, it should be effective against COVID-19 disease or SARS-CoV-2. I'm not, I mean, they don't have data to back that up. But, cleaning with, disinfectant wipes is better than not doing anything. Okay, I think I've answered all the questions here.
Okay, thank you very much, Dr. Tashfeen. For attendees, I would request if somebody wants to speak, or we can unmute, and he or she should raise the hand, please. Dr. Ijaz Rashid, probably. Can you hear me, please?
Hello?
Yeah,
Hello?
yeah. Go ahead, please.
Yeah, I just want to comment that it was an excellent talk, very informative and very useful. Thank you very much, Dr. Tashfeen Mahmood, for your time.
Thank you.
So, thank you. Thanks a lot.
And Dr. Mirza Beg.
I would like to know when a person can declare that there is no more COVID virus in the patient.
Okay. All right. So I think I did talk about it briefly in my presentation, but it's a very good question. There are two ways to do it. One is symptom-based and one is testing-based. So if you go by symptom-based, the current recommendation is uh, 10 days after onset of symptoms, and followed by that 3 days of symptom-free. Like symptom-free mean no fever, no respiratory symptoms, no constitutional symptoms. So they're good to go. The other approach is no symptoms from symptom onset. 10 days have passed and there are no symptoms. You do testing. What testing is RT-PCR. And if it's negative, you repeat the testing for after more than 24 hours. And you can use any method of testing. And if it's RT-PCR is negative, you're good to go.
And next, Dr. Javed.
Sir, I want to get your comments that many consultants from all over the world, they are supporting the conspiracy theory that this virus is man-made, data being given about the death rate that is false. What are your comments?
The virus came from bats. That's what I know. Now, how it got out into community, it's another debate. There are a lot of theories out there, and I have not investigated into that, but I think it's a zoonotic virus. It came from bats, and it was in the lab, and it got leaked by some way. I don't know how, but they're all different kind of theories.
Dr. Tahir Chaudhary, please.
Assalamu alaikum. Thank you very much, Dr. Tashfeen, for such a wonderful and elaborative talk. And honestly, I learned a lot from your talk. Thank you very much. My question would be that, as you know that, and you have also mentioned in your talk that this COVID-19 is a disease which is, a disease of hypercoagulability. We have tons and tons of patients with diabetes in this part of the world and in whole of the world as well. Do you suggest the role of aspirin or clopidogrel for a period of 3 to 6 months or period of pandemic in all the diabetic patients who otherwise have no indication to prescribe aspirin or clopidogrel?
Very, very good question. And to be honest with you, I don't know the answer is correct to this. But again, I think there was an earlier study in which they combined anticoagulation and clopidogrel on these patients. It is currently not recommended based upon lack of data. But again, it's if there is not much risk of bleeding, and you trust your clinical acumen, I think a baby aspirin, I'm not sure about clopidogrel, but a baby aspirin may be just fine. But again, I'm not an expert to comment on that, and I can't be very sure about it. But there is, I think, a trial going on in community to look at it. But we have to understand that at earlier when it all started, we did not have proper ways to even tell who is infected. Then telling who are the people who have carried on immunity, or they have been immune, or for some reason they have not developed clinical disease, but they have positive antibodies. So I think it's an idea. I'm unable to comment that what would be the outcome if we do that.
Dr. Tariq Mahmood, please.
Thank you very much for arranging such an excellent webinar. Basically, I want to ask two questions. Number one, what is your experience regarding the plasma therapy, plasma of cured patients of COVID-19? We have got in Pakistan a few cases, although they are few in number, but very good results over here. Secondly, there are many patients which are after being negative from COVID-19, they are again coming to hospitals with myopathies and things like that. What's your comments?
So to answer the first question, I agree with you that what the plasma recovered from cured patients is a convalescent plasma. And yes, it does have excellent results. I think when Dr. Javed Akram launched this study, I was in touch with him, and we are part of the expanded release of plasma under Mayo Clinic, and we ourselves have seen phenomenal results. So it does work. The second question is that these people coming back with myopathies with tests being negative. Honestly, I have not seen them coming back, but this is one of the problems with any prolonged illness, that you are going to have a critical illness related myopathies and neuropathies as a sequelae of the disease. So it's too early to say, because we don't have data in front of us, that how do these patients would actually behave in long term. The question about reinfecting is also out there. It's not very clear. So that also leads us to if all of us are going to get immune if we get infected, what kind of antibody persists and how long it persists, and is it protective in everybody? It's hard to say at this point, because the serological tests, which are more validated now, are just being now started to being available. So yes, I would anticipate some kind of sequelae of the disease in those patients, but it's too early to say which one would have that and how long those things will go. Just like for ARDS, some of the patients get on room air after being treated, and some of them require on baseline supplemental oxygen for the rest of their life.
Dr. Ayub Khan?
Yes, Assalamualaikum. It was a nice presentation. I want to ask that ACE inhibitors are given to the patients having some sort of nephropathy. And here, if we are to stop it, rather we can say that COVID-19 is going to attach to the ACE inhibitors receptors in the pneumocyte. What is the benefit to stop it?
Okay, this is a very controversial topic, and so what you're asking me, that people who are on ACE inhibitors, there are all kind of theories, because the SARS-CoV-2 virus actually in any tissue it infects, talking about pneumocytes type 2 in lungs, does attach to the cell via ACE receptors. So if a patient is on ACE inhibitor or ARB, what is going to happen, they have upregulated their receptors, and these patients are more prone to have disease. Again, this is one theory, okay? The other theory is that since the ACE receptors are already occupied by ACE inhibitors or ARBs, these patients, I would say ACE inhibitors, these patients are less likely to contract the disease. There is no such evidence that it does happen. On the other hand, if the ACE receptors are not blocked, the ACE levels go up and causes vasodilatation in these patients and causes more shunting and cause more problem with oxygenation, and these patients are sicker, is also a theory. There is nothing proven. There are all kind of, you'll see all kind of social media posts, and so this has been negated from several forums, and I do not recommend, and none of the bigger societies, including American Cardiac Society, they don't recommend stopping ACE inhibitors or ARBs in these patients, because what you're doing, the benefit of keeping them on this therapy, it actually outweighs taking them off for something that is more theoretical based. Same way, we do not recommend putting those patients on ACE inhibitors or ARBs if they are not already on those. just because the lack of data, and we don't know which way actually these patients are going to go. So that's very clear. If a patient is on ACE or ARB, continue that. And if they are not, don't start that just for treating COVID.
Dr. Tashfeen, I think there is a one written question, if you don't mind, in the end.
Okay. Okay, so how we should go for central air conditioning in hospital building? Is there a real risk of virus spreading if suspected or confirmed cases of COVID-19 are coming to hospital? Very, 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 very good question. And I think this is a very practical question. And I believe I answered it somewhere above, that, you know, if you don't have, if you have a split air conditioning system, and you are circulating the same air, you are basically providing a very rich culture for the virus to spread and grow in that area. So it's a pipe open to you know, any kind of issue we are dealing with here. So unlike in USA and developed countries where we have what we call HEPA filters and negative pressure rooms, I don't think so those are going to be available readily, at least in countries like Pakistan or India. So what we need to do is stress upon open ventilation. And what WHO also says that, you know, if you have open ventilation, keeping windows and door open, and if your air is circulating at least 12 to 14 times in an hour, your ventilation is actually as good as a negative pressure room, or even better than that. So it's very important not to keep the area crowded and closed, because it can be more detrimental.
Okay, there is one hand raised by Dr. Tariq Mahmood.
Hello.
Yeah, that's fine. We can hear you now.
Yeah. Thank you so much, Dr. Iftikhar and Dr. Tashfeen. We are very thankful for arranging such an excellent webinar, because most of the Pakistani physicians, and particularly the family physicians, they were in search of such an excellent talk so that they can clear their doubts, because on social media and everywhere there are different perspective of this disease, because it is a few months old disease. So I think with this webinar, most of the people, and I'll request you to please give a video recording of this webinar so that we can disseminate in our members, which are thousands in number, and due to shortage of time, they cannot connect. So I think that will be better idea.
Yeah, that's fine. We will be providing you the seminar, the recording, please.
Thank you
very
so
much,
much.
Dr. Tariq.
Thank you.
And there is one more question. I think somebody has written in the chat. What are the factors that the progression of COVID will be slowed down in future? Dr. Tariq Mahmood.
So again, you know, one is we think that there is some idea. I was going through, there's an article came up that there is some structural change to the virus itself. Now, it's a very preliminary data, and it's showing that virus can be less virulent. So that's one thing. The other thing is just like, you know, flattening, we're talking about flattening the curves and going down. I still believe, like any respiratory virus, it's going to be controlled by you know, social distancing and, you know, best practices of cleaning, keeping hygiene, all those measures. It's going to ultimately creep through summer, as far as I know, in USA, and then it's going to slow down. And then there is a second wave. It's going to come. And the most important thing is not to open up things prematurely, considering your local spread and, you know, your community and what you are dealing in-house. So I still believe, like any respiratory virus, it's going to come back. I believe that the immunity is going to be there from first infection. I don't know how long it would last. So I believe it's maybe 1 or 2 years. I don't know. The vaccination, I think, is due in September. That's what we are hearing. And once it is, it's going to be a game changer. Same way, having the serological tests, which are well validated, are going to help us in learning the actual disease prevalence. And it would also tell that how many people just got like maybe a mild flu-like illness and they got better. They didn't need to seek any medical attention. So they got, over this without any help. So it's too early to say, but they're all kind of speculations.
Dr. Tashfeen Mahmood, please.
Yes, Dr. Iftar.
Yes, please.
Actually, I'll request you that please, whatever the updates regarding this COVID-19, because my son is working in UK also, and he was working in a corona ward. He was saying that many patients who were cured and they were discharged, and they came with the cardiomyopathy. So I think if there are any updates regarding COVID-19, I'll request Dr. Tashfeen Mahmood and you, Dr. Iftar, also please do share any update which are beneficial to the Pakistani physicians, so we can send all the information to our physician. So it will indirectly it will help our Pakistani position, Pakistani people, because the government has relaxed lockdown. So I think the people are not caring, they are not taking this disease as a serious disease. So I think there will be a lot of spread in these days. So anything which can be beneficial for the people of Pakistan, please do share with us so that we can also share with our people through media and to the Pakistani physicians.
Okay, thank you very much. Dr. Tashfeen, please, you can comment on.
Yes, so cardiomyopathy is one of the known complications. From anecdotal reports, it seems like it happens, and it does happen a little late into the disease. So it's possible those patients were discharged a little early and they came back with cardiac complications. But yes, it does happen. Fortunately, it's not that common. I would say about, anywhere from 10 to up to 1/3 in certain reports. I have not seen it up to 1/3, but then again, as you said, it's too early, and if we have more information on it, we will definitely love to share that with you.
Thank you very much. And Dr. Tariq, we will also try from UK to update anything which comes up here. And do check our website, iradreporting.com, for any updates, please. Thank you. And I think all is done. Dr. Tashfeen Mahmood, thank you very much. I think everybody learned and everybody shared their experiences also. So we are really grateful to you for your time. I know you are very busy.
Always happy to help.
Thank you very much for all the attendees, and you will receive an email for feedback. Please fill that, and then we will send you your attendance certificates. Okay, thank you.
Thank you.